Uh, Hi, good morning, everybody. I am Dr. Kumar Abhishek, AP Assistant Professor in Pulmonary Medicine, GMC Bethia. Today on online classes, I am going to taking the class on the pleural effusion. It is the one of the most common respiratory problem in the pulmonary department, and during day-to-day practice, most of the patient we can get the come into the OPD or emergency as a pleural effusion. So we detail the see the pleural effusion overview. In this slide, we see the content of the slide: the introduction, classification of the pleural effusion, what is the pathogenesis of the pleural effusion, etiology of the pleural effusion, clinical features, investigation, management. One by one in details we go through the slides. From the introduction, what is the pleural effusion? It is nothing come to just the some anatomical basic anatomy of the airway. This is the trachea, windpipe, and this is the two lungs. The two lungs is covered by the inner layer is the visceral pleura and the outer layer is the parietal pleura. And both the inner layer, visceral layer and parietal layer cover the lung. There is the thin space between the parietal layer and the visceral layer. And the pleural effusion is the collection of fluid in between the visceral pleura and the parietal pleura. So pleural effusion is defined as the abnormal. This word is the abnormal because there is some physiological fluid present in the between the parietal and pleural pleura, which is very minimal, and it is absorbed by the lymphatic system of the lung. But pleural effusion is defined as this is the abnormal accumulation of fluid between the parietal and the visceral pleura. Normally, the pleural space contains 0.3 ml per kg body weight of the pleural fluid. There is a continuous circulation of fluid in the lymphatic vessels and can cope with several millimeters of extra fluid per 24 hours. So, in the physiological, normally the pleural space contains normally 0.3 ml per kg body weight of pleural fluid, and this fluid is continuously absorbed by the lymphatic system of the lungs. So fluid accumulate in the pleural cavity. Why the fluid accumulate in the pleural cavity? There is the pathogenesis is that there is either the alteration of the hydrostatic and the oncotic pressure, or either there is the change in the permeability of the pleura. These are the two main pathogenesis by which the pleural fluid collect in the between the parietal and the visceral pleura. So, and this is the definition. This is the different type of the effusion. The effusion is the broad spectrum, and these are the components, subcomponent of the effusion. That is what is the parapneumonic effusion? Parapneumonic effusion is nothing. Pleural effusion which is associated with the parenchymal pneumonia or bronchiectasis or lung abscess. If the effusion is associated with this component, with pneumonia, bronchiectasis or lung abscess, then we can say that effusion is parapneumonic effusion. Locculated effusion. Generally, fluid anatomically collect between the parietal and pleural fissure and shape convex shape. But in the locculated pleural effusion, fluid anatomically confined and not freely flowing in the pleural space, and there are adhesions. Why the locculation is occur? Locculation is occur if there is not freely moving the fluid. There is some adhesion between the parietal and the visceral pleura. Due to this, the fluid is locculated. It is not moving. It is just confined into the just one location. And the subpulmonic pleural effusion, accumulation of fluid between the lung and the diaphragm, which gives the false impression of the elevated hemidiaphragm. The most of the causes of the subpulmonic effusion is the abdominal pathology. There is the effusion, accumulation of fluid between the lung and the diaphragm, which gives The impression the diaphragm elevated hemidiaphragm, and most of the causes of the subpulmonic effusion is the abdominal. What is the composition of the pleural fluid? Normal physiological composition of the pleural fluid. The normal volume of the pleural fluid is the 0.3 ml per kg body weight, and this normal pleural fluid contains 1000 to 5000 cells, and the component of this cells is the 60% component is the mesothelial cells, 30% is the monocyte, and 5% lymphocyte, and the 5% is the neutrophil. And the protein content is the 1 to 2 gram per dl. LDH is the less than 50% of the plasma serum LDH, and the glucose is nearly equivalent to the plasma level, and the pH is slightly greater or equal to the plasma level, 7.4 or 7.5. The pleural effusion is classified on the basis of the location, on the basis of the cause of the effusion, or maybe the pleural effusion is unilateral or bilateral. So unilateral, if the pleural effusion is involved only the right side or left side, or bilateral pleural effusion, accumulation of fluid on the both sides. And by the location, pleural effusion is classified as the apical, interlobar, subpulmonic, mediastinal. This is all the interlobar. There is the lungs is the divided, lobes are divided by the major fissure and the minor fissure, and the subpulmonic already I have discussed, and the mediastinal, because this effusion is collected the pleura, pleura is divided by the mediastinal pleura, parietal pleura and the visceral pleura. This, if the effusion is collected between the mediastinal lining of the visceral and parietal pleura, then this is called the mediastinal pleural effusion. This, and what is the type of the pleural effusion? This is the main categorization of the both broad spectrum of the pleural effusion is classified on the basis of these two etiology: transitive pleural effusion or exudative pleural effusion. The causes of the transitive pleural effusion: if there is alteration between the hydrostatic pressure and the oncotic pressure, and exudative effusion is that if there is alteration in the permeability of the pleural line pleura. And based on the mechanism, etiology, and type of the pleural effusion, if the pleural effusion is infective cause, this is the pathogenic, likely the parapneumonic effusion. If there is the pneumonia with effusion, this is the pathogenic. Or if there is the empyema, pus collection due to tubercular or infective. Chylous effusion is that the effusion is due to the milky effusion. This is just like the whitish milk, like the collection of pleural fluid. This effusion is due to the disruption, traumatic disruption of the thoracic duct. We come into the latter slide. Hemothorax is that if collection of the blood in the pleural fluid. Pseudocylothorax is that one variety of the pleural effusion. And hydrothorax is that most of the transitive pleural effusion be categorized in the hydrothorax due to the congestive heart failure, hepatic cause, or the renal cause. Urinothorax, there is the accumulation of the urine in the pleural cavity. So, most of the pleural effusion categorized as the transitive pleural effusion or exudative pleural effusion. What is the cause of the transitive pleural effusion? We already have discussed. If there is the we already in the pathology we say that there is the equilibrium of the between the hydrostatic and oncotic pressure. Due to this, if there is the alteration of balance between the hydrostatic and oncotic pressure, this leads to the formation of the fluid. So, in the transitive pleural effusion, there is the alteration of the hydrostatic and the oncotic pressure that increase the formation or decrease the absorption of pleural fluid. This leads to the transitive pleural effusion. The cause of the transitive, the three is the most common causes of the transitive pleural effusion: heart failure, liver cirrhosis, and the nephrotic syndrome. The hepatic cause, heart cause, and the renal cause. These are the three most common causes of the transitive pleural effusion. And in the transitive pleural effusion, the fluid is accumulated due to the alteration of balance between hydrostatic and the oncotic. We are already, what is the etiology of the exudative proliferation infective cause? This is the pneumonia, bronchiectasis, pancreatitis, tuberculosis, which is the most common endemic cause in our country, lung abscess. And the collagen vascular disease also causes the exudative proliferation, like the SLE, RA, polyarthritis, and the malignancy. Malignancy is also the cause of the exudative proliferation. Different type of the malignancy, leukemia, lymphoma, and other type of the malignancy. Uremia. This is due to the uremia. This is due to the CKD, chronic kidney disease, also cause the both the transitive and the exudative pleural effusion. If there is the fluid overload due to the chronic kidney disease, this lead to the transitive pleural effusion, and if there is no only this fluid accumulation, then that uremic pleural effusion, if there is the rise of the creatinine and the accumulation of fluid into the parietal and the visceral fluid, this may lead to the uremic pleural effusion. By the biochemical criteria, we can differentiate between the transitive and the exudative pleural effusion. And that some are the drugs which are the more common causes of the exudative pleural effusion. And these are the MCQ question for the in PG entrance. What are the drugs that causes the exudative pleural effusion? Those are the isoniazid, amiodarone, nitrofurantoin, bromocriptide, PAS, and the nitrofurantoin. This nitrofurantoin is used in the UTI, amiodarone is used in the antiarrhythmic drug, INS is the antitubercular, PAS is the antitubercular drug, and the trauma is also causes the traumatic exudative pleural. Come, infective cause, pyogenic, the lung abscess due to infection, septicemia, if there is a chest wall injury, rupture of the esophagus, rupture of the subphrenic abscess, or rupture of the liver abscess. This causes the pyogenic exudative pleural effusion. Chylous pleural effusion, we have already discussed. This is the milky collection of fluid in the parietal and the visceral pleura. This is due to the either the trauma of thoracic duct or either the neoplasm. These are the most two common causes of the chylous pleural effusion. This is a lymphoma or the trauma to the thoracic duct due to the any injury or due to any thoracic surgery. Tuberculosis and the lymphatic obstruction. These are the rare also the causes of the. The hemotherapy. What is the hemotherapy? Hemotherapy is nothing collection of the blood into the parietal and the between the parietal and the visceral fluid. This hemotherapy occurs chest wall injury or either as any bleeding disorder or patient or either neoplasm like the leukemia, lymphoma, mesothelioma. This also the hemorrhagic collection of the fluid. This is called the malignant pleural effusion. Drug, if the patient is on either anticoagulant or antiplatelet drug, and the pulmonary infection due to the pulmonary embolism. These are the causes for the hemotherapy. and the renal also cause the three most common causes for the transitive pain. This you are also called the hydrotherapy. Hydro, nothing, there is the accumulation of the water. What is the presentation of the patient? If any patient present with the pleural effusion, how they can present with in the OPD department or emergency department? The clinical presentation is that underlying cause of the effusion usually dictate the symptom. Although some patient may be asymptomatic. If the patient is the cardiac patient, if the patient has a liver cirrhosis, if the patient is a renal, then the underlying clinical symptom detect the cause of the effusion. And there is the pleural inflammation, abnormal pulmonary mechanics, and worsen alveolar gas exchange produce symptom and sign of if there is the accumulation of the fluid between the parietal pleura, the lung is collapsed, and this lead to the abnormal worsening of the gas exchange. So, what is the symptom and the sign if the patient present with the pleural effusion? If there is the due to the inflammatory cause of the pleural collection, then there is the inflammation of the parietal pleura lead to the pain. This is called the pleuritic chest pain. Characteristic of the pleuritic chest pain, this is the localized, and the pain increase during the inspiration, and the pain also sometimes referred to the lung due to the phrenic nerve irritation. So, characteristic of the pleuritic chest pain is that this is the localized chest pain, increase during inspiration, and sometimes distributed to the shoulder due to phrenic nerve irritation. And due to the effusion, patient may present with the dyspnea. And the shortness of breath occur how the amount of effusion collection. If the small amount, the patient do not complain dyspnea. If the massive effusion is there, the patient come with the shortness of breath. And the cough can occur, and sometimes fever if there is the infective cause for the effusion is there. And the cough, most of the nature of the cough in the pleural effusion is the dry cough. Come to the physical examination. If the patient of pleural effusion come to the emergency or OPD, there is the four part of the physical examination: inspection, palpation, percussion, auscultation. In inspection, there is the movement of the decreased chest wall movement of the affected side, and sometimes there is the fullness of the chest wall with intercostal bulging of the intercostal space we can find in during the inspection. And in the palpation, there is the diminished breath sound over the site of the effusion, and the decreased or absent tactile parameters. Ask the patient to how we can differentiate the decreased absent tactile parameters. Ask the patient to speak the 333 or 999. So during the palpation, you can feel there is the decreased movement and decreased vocal sound resonance of the patient. That is the absent or decreased tactile parameters. Percussion. In the percussion, there is the stony dullness of percussion on the site of the effusion. And the auscultation, there is the absent of breath sound over the effusion. Vocal resonance is also decreased. And if the patient is associated with the pneumonia, there may be the bronchial breath sound or trachea may be present. How we can confirm the pleural effusion? Come to the investigation part. If the patient you can suspect the pleural effusion, go to the first of the chest X-ray. Radiological examination. Chest X-ray is the basic for the diagnosis of the pleural effusion. In the chest X-ray, PA view in erect position, a total 300 ml if there is the fluid collection, there needs to the diagnosis of the pleural effusion. If there is a less effusion, even 50 ml of the fluid can demonstrate radiologically if you can take the X-ray in the lateral decubitus. So X-ray is the basic, and we come up later on the investigation. In the X-ray, what we can find radiologically, there is the obliteration of the costophrenic and cardiophrenic angle. There may be the loculated effusion, or there may be the subpulmonic effusion. We already discussed there is the fluid below the diaphragm lead to the elevation of the diaphragm. That is the called as the elevation of the hemidiaphragm. This is confirmed by the lateral decubitus. And in the lateral decubitus, how can we take the lateral decubitus X-ray? In the lateral decubitus, affected side is on the outside, and the lateral decubitus on the side effusion will show shift in the fluid level. And also the radiologically, if there is a massive effusion, tracheas or mediastinum is shifted to the opposite side if the effusion is very massive. In the loculated pleural effusion or subpulmonary effusion, there is no mediastinal shifting. So on the chest X-ray, you should this is the obliteration of the cardiophrenic and the costophrenic angle. This is the minimal effusion. There is no any mediastinal shift, and this is the lateral decubitus film is there. During the removal of the diagnostic aspiration of the fluid, we always see the color of the fluid. The fluid is the straw color, your fluid is the blood tinge, your fluid is the pus, or the fluid is the purulent, or fluid is the chylous. This is the blood stained fluid. This is the straw color, and this is the pus collection is there, and this is the milky white effusion is there. This is the chylous blood effusion. How can we differentiate the transdate and disdate pleural effusion by the biochemical appearance? The clear straw color, this may be the transdate. In exudate, colored, cloudy, turbulent, and the turbid fluid is there. In the transdative pleural effusion, protein is less than 3 gram per 100 ml. In the exudate, it is more than 3 gram. pH is greater than 7.2 for the transdative. In exudate, it is less than 7.2. Glucose is greater than 40 mg per dl in the transdative fluid, and exudate is less than 40, and the LDH is the low for the transdative fusion, and exudative fusion it is the high, and in the transdative fusion cells is also within the physiological level limits, less than 1000 per millimeter cube. On exudate it is greater than 1000 per millimeter cube. By the lights, this is the famous criteria for the differentiation between the transitive and exudative effusion, the lights criteria. At least one of the following criteria should be assessed to identify the exudate. If blood fluid to serum fluid to serum total protein ratio more than 0.5, blood fluid to serum LDH ratio more than 0.6, or blood fluid to LDH more than blood fluid LDH is more than 2/3 of the serum LDH. Any of the three, if any of the three meets, then that is the exudative blood pressure. If none of these meet, then this is the classified as the transitive blood pressure is there. So by this the biochemical criteria we can differentiate the transitive or exudative blood pressure. Other is the Roth criteria. If the gradient serum and the blood fluid gradient, albumin gradient is more than 1.2, it is the transdate effusion. And the pleural fluid appearance, we can discuss in that the most transitive effusion clear, straw color, non-viscid and without any odor. And the red tinge pleural effusion indicate presence of blood. Bloody pleural fluid, may be due to the hemorrhagic pleural effusion, or it may be due to that during the aspiration there may be the trauma. If the pleural effusion is bloody due to the thrombocentrisity during the aspiration, the degree of the discoloration of the fluid clear during the aspiration. If the fluid is not hemorrhagic, that fluid not clear during the aspiration. The color is uniform. Bloody pleural fluid will indicate already a malignant pleural effusion, trauma, pulmonary embolism. How can biochemical we can differentiate that this is the hemothorax? Presence of gross blood should lead to measurement of pleural fluid hematocrit. If the pleural fluid hematocrit more than 50% of the serum hematocrit, it indicates the hemothorax, and that this reduces the drainage by the chest tube. If, the, if we can spread the pleural fluid in the diagnosis, what we can send for the biochemical investigation. For the biochemical investigation, we send the pleural fluid glucose, LDH. If you are suspecting the pleural effusion is due to the pancreatic or esophageal rupture, you send the amylase, ADA, and the LDH. These are the other most important. You can send the pleural fluid for the TLC, DLC, glucose, LDH, protein, albumin, ADA, and the cytology. If you are suspecting the pleural fluid is for the pancreatitis, you can send the amylase also. And pleural fluid microbiology, during the pleural fluid we send also the gram staining, AB staining, pleural fluid culture, AB culture, and the gene expert for the tuberculosis. Lymphocyte, if the pleural effusion greater than 50% is the lymphocyte, then the suggestive of tuberculosis or malignancy. If there is the presence of mesothelial cells in the pleural fluid, your suspicion for the tuberculosis is very less. If there is the plasma cell present in the fluid, we suspect the multiple myeloma. So by the cytology, we can categorize the etiology of the pleural effusion. Glucose, come to the parameter glucose. A glucose concentration less than 60 mg per is due to the malignancy, tuberculosis, rheumatoid, or parapneumonia. These are the three: RA, TB, malignancy, and the parapneumonic effusion. This lead to the less than 60 mg per dl of the glucose. And for the parapneumonic effusion, if the effusion contain glucose is less than 60, we go for the tube thoracostomy (ICD) for the removal of. This is the one of the criteria for the chest tube insertion of the for the effusion. If the glucose is less than 60 in the effusion. Pleural fluid pH. This is in the day-to-day practice. This pleural fluid is not pH is not measured. So low pH is due to the empyema, tuberculosis, malignancy, collagen vascular disease, or esophageal rupture. But in our day-to-day practice, you can we do not measure the pleural fluid pH. Amylase. If you are suspecting there is the esophageal rupture or there is the suspecting the pancreatic pleural effusion, elevation of amylase suggests that patient has a pancreatic disease or malignancy or esophageal. These are the three broad causes for the elevation of amylase in the pleural fluid. Malignancy and esophageal rupture causes have the salivary component of the amylase elevation, and the pancreatic pleural effusion pancreatic amylase. But we can do not differentiate the salivary amylase and pancreatic amylase elevation because this needs the higher laboratory investigation. So we can only send the total serum amylase in the pleural fluid. We cannot differentiate salivary amylase and the pancreatic amylase. If the pleural effusion is the turbid or milky fluid, after centrifugation, if the supernatant color, after the centrifugation of the pleural fluid, if it clear and cloudiness is likely due to the cells and debris. If supernatant remain turbid and pleural fluid triglyceride is greater than 110 mg per day, who suggests this is the chylothorax. So, if you suspecting the fluid is very milky and the color is, if supplement clears, the cloudness is likely due to cells and debris. If you suspect this is the due to the chylous effusion, you can send the triglyceride of the pleural fluid. If the triglyceride is greater than 100, it is due to the chylous pleural effusion, chylous suggestive of chylothorax. And already we have sent know the etiology of the chylothorax. Cytology. 60% pleural effusion cytology is positive for the malignant. If there is the effusion is due to the malignant etiology due to some malignancy, in the 60% cytology is positive for the malignant cell if the etiology is due to the malignancy. The volume of the pleural fluid analyzed does not impact the yield of cells. Sometimes during the first thoracocentesis, the cytology is negative. But repeat cytology, if you send the sample second time or third time, there is the yield of the cytology for the malignant cell increase. So volume of the pleural fluid analyzed does not impact the yield of cytology. But repeat thoracocentesis increase the diagnosis. Thoracocentesis means removal of the pleural fluid from the thoracic cavity. And this may be either diagnostic or therapeutic. Urinothorax. These are the rare causes of the pleural effusion due to the collection of urine in the pleural cavity. This is due to the obstructive uropathy or this is due to the trauma during surgery or any traumatic. Urine arrives in the pleural space either retroperitoneally under the posterior diaphragm via the retroperitoneal or via the retroperitoneal lymphatic. How can you diagnose the urinothorax? The pleural fluid smell like urine and pleural fluid send the pleural fluid creatinine and the serum creatinine. The ratio is almost equal. Then you can suspect the urinothorax. If you suspected the pneumonia, you send the pH. If you suspect pancreatitis, you send the pleural fluid amylase. If by the thoracocentesis, a diagnostic aspiration, if you do not know the etiology, if you do not know the conclusion why the pleural effusion is accumulated, if you do not know the etiology of the pleural effusion, then by the diagnostic aspiration, then you can go for the pleural biopsy. But before the pleural biopsy, you go for the ultrasound or a CT scan for where the yield is very high, because this is the blind etiology, blind procedure. But in now during in the modern era, as the pulmonary science is very evaluative, the pleural biopsy is very not performed in most of the center. This is the diagnosis by the other method by the like the pleural biopsy can done at the maximum dullness or percussion at the maximum thickening of the pleural space. Abraham's needle, this is the Abraham biopsy needle, is used for the biopsy. It is helpful for the tuberculosis and the carcinoma. And if in the modern era, the thoracoscopy is the gold standard for the diagnosis of the etiology of the pleural effusion. This is the pleural biopsy blind procedure. This is done if you have no facility of the thoracoscopy. This is the biopsy needle, cutting biopsy needle, by which we take the biopsy from the parietal layer and send for the histopathology. On that we can see what is the etiology of the pleural fluid. This is the Abraham needle. After investigation, we come in the part of the management part. If the patient is dyspneic, we go for the supportive treatment. If you are suspecting the etiology of the pleural effusion due to the infective, insert the IV antibiotic and the chest radiography and ultrasonography useful for the quantification of the pleural effusion. If you are suspecting the pneumonia, you start the antibiotic. If you are suspecting the community acquired pneumonia, you start the cephalosporin for maxillary and the clindamycin. If you are suspecting that this is the hospital-acquired pneumonia, you give the broad spectrum antibiotic for both the coverage of the gram-negative organism. If you suspecting the tuberculosis, start anti-tuberculosis. If the patient is due to the transductive effusion and if due to the cardiac cause, heart cause or a hepatic cause, you treat the causes of the effusion due to the transductive effusion. If the patient is a cardiac failure, give the diuretics and other heart medication. Surgical. Where is the indication for the insertion of the ICD in the pleural effusion? If the pleural fluid aspiration is done by using a wide bore needle, if the fluid is viscous, cannot drain by a needle, if there is the collection of pus, you can go for the intercostal tube under water seal. At the most dependent part, it is most done in the 5th to 6th axillary in the axillary region between the this is the axillary region 5th to 6th aspect. This is the safe triangle of the safest angle of the triangle, safe triangle for the insertion of the ICD between the anterior border of the pectoralis major and posterior border of the pectoralis major and anterior border of the latissimus dorsi. What are the indication of the surgery? Empyema, if there is a collection of pus, you go for the ICD. If during the effusion, if your microorganism is present, the gram stain is positive, go for the ICD. If the glucose is very less in the pleural fluid, go for ICD. And pleural fluid pH is less than 7. How we can spread the pleural fluid? Pleural fluid aspiration is done by using a wide bore needle. This is the wide bore in 18 gauge or 16 gauge needle. If the fluid is thick and cannot drain, you can go for the intercostal. If during the diagnostic or therapeutic aspiration, you can 5th to 6th intercostal space in the interscapular region. Give the patient to the table and the cushion and ask him to support him with both arms and bend forward. And you can insert the needle in the 7th intercostal space in the intercostal aspiration with the negative aspiration. And then you can go for the collection of fluid collection in the bag or bottle with a three-way system. These are the procedures which are demonstrated during the clinical rounds. So, pleural fluid aspiration done by using a wide bore needle. If the fluid is thick and cannot be drained by a needle and intercostal drainage, undergo for water seal at the most dependent part. Indication of the ICD: if the pleural fluid is loculated, recurrent pneumothorax, if the effusion is massive, if there is the hydropneumothorax, a pneumothorax, if the empyema or a hemothorax, or in the parapneumonic effusion. If the effusion is associated with pneumonia, what are the conditions? You can go for the tube therapy. Positive stain for the microorganism, pleural fluid culture is positive for any organism, pleural fluid pH is less than 7, or pleural fluid glucose is less than 60 or 40. This is the underwater seal bag. This is the plastic bag and this is the bottle, glass bottle. Underwater seal bag is used because this is the one-way valve system. The fluid is accumulated from the pleura to in this way, but air or atmospheric air or other is not going to the pleura due to this one-way check valve is there. So underwater seal bag is used as one-way valve mechanism. The air or fluid or pus from the pleura enter the water space, but the atmospheric air cannot go into the pleura because this atmospheric air and escape from here. And this is the plastic. This is the cheaper. This is some costly there because this is the plastic bottle. These are the method how we can insert the ICD. By this is the multiple fenestrated different size of ICD come. If they suspect the pus, you can go for the bite 32 French or 28 French intercostal tube. This is the how the intercostal tube can be inserted by the local infiltration and the minimal incision without any sedation. You can give in the fifth or sixth intercostal space in the axillary mid axillary line, and this is the insertion. After the insertion, you can go for the switch, fix the ICD by switch and always see fluid is coming or not, and during aspiration the column is moving or not. If the column is moving, your tube is in the right place. If this is the chest tube is there, this chest tube. If there is this collection, black collection is there, this is the pneumothorax, and this is the collapsed line, and ICD is here. This is the different type of 3 bottle system for the ICD. This is the plastic system, 1 or 2 bottle chamber, 1 bottle chamber, or this is the plastic. The same is, this is the one valve mechanism is there. Blood aspiration, during the blood fluid aspiration. Thank you.